This is gimbal performing what it then called continuous stare capsulotomy. This technique developed over 30 years ago contemporaneously with Neuhen, who named it as we know it today, still remains as the standard technique for opening the anterior capsule during cataract surgeries. Capsulorhexis made cataract removal safer and opened up a whole new set of possibilities for the evolution of intraocular lenses. But as my Uncle Ben, an experienced ophthalmologist, would say, with great innovation comes new complication. This statement turned out to be correct. In 1993, Davison described a complication in which a shrinkage of the capsular bag would occur following cataract surgery with capsulorhexis and named it the Capsular Contraction Syndrome. This syndrome can lead to further complications such as complete encapsulation and displacement of the IOL. In the following years, several studies pointed out the association of Pseudoexfoliation Syndrome with the development of Capsular Contraction Syndrome following cataract surgery. That led to a whole new set of studies focusing the prevention of this syndrome in eyes with pseudoexfoliation. Making a larger capsulorhexis, selecting proper IOL materials and designs, placing one or multiple endocapsular rings, and the rigid control of inflammation in the postoperative are helpful to lower the rates of capsular contraction, pseudoexfoliative eyes. None of these strategies, however, have completely avoided the possibility of this complication. There are several reports on IOL bag complex and even IOL CTR bag complex displacement, which are most likely related to some degree of capsular contraction. To better understand why capsular contraction still happens despite our efforts, we must go back to the pathogenesis of capsular contraction syndrome. After cataract extraction and IOL implant, two forces act onto the capsular bag. A centripetal force, exerted by the opacified anterior capsule, and a centrifugal force, exerted by the zonule. Capsular contraction occurs when there is an imbalance in those forces. That is, when the centripetal force of a fibrous anterior capsule outperforms the centrifugal force of weakened zonule. In pseudoexfoliation, zonules are known to be weakened, and on top of that, some studies suggest that there is a break in the blood aqueous barrier, which may exacerbate the inflammatory response in the postoperative period and further intensify the fibrosis of the anterior capsule. So, can we eliminate the centripetal force and therefore avoid capsular contraction? Anterior capsule opacification occurs as a result of the lens epithelial cells' activity. The epithelial cells remaining at the edge of the anterior capsule undergo fibrous metaplasia, which is followed by collagen production and finally contraction of the anterior capsule. In 1989, Nishi suggested that vacuuming the undersurface of the anterior capsule would significantly reduce the amount and the effect of residual lens epithelial cells. In 2005, Tadros proved that the removal of anterior subcapsular lens epithelial cells by aspiration helps maintain the size of the capsulorhexis opening in normal eyes. With that in mind, we decided to try and aspirate the lens epithelial cells in patients with pseudoexfoliation syndrome undergoing cataract surgery. One major difficulty with this procedure in those patients is the poor pupil dilation they usually present. In this video, I will present a simple technique to overcome this issue. After the removal of the nucleus and cortex, we will proceed with vacuuming the epithelial cells on the posterior surface of the anterior capsule by quadrants, using bimanual irrigation and aspiration. With the irrigation cannula placed between the iris and the anterior capsule, we gently lift the iris towards the cornea and push it towards the angle. This way, we are left with enough visualization of the anterior capsule to make it safe to place the aspiration cannula under the anterior capsule and proceed with the aspiration of the epithelial cells. Once the vacuuming of a quadrant is complete, we move on to the next one. It is important to be careful not to let the tip of the irrigation cannula placed anteriorly to the anterior capsule touch the tip of the aspiration cannula placed posteriorly to the anterior capsule, as this would easily tear the capsule. In our cases, the amount of vacuum needed to achieve proper removal of the epithelial cells varied from 20 to 100 millimeters of mercury. This is a very safe zone if we consider the work done by Saber in 1998, when he showed that we can go as high as 150 and still be safe. In the first three cases, we left the epithelial cells intact in the right eye and performed the aspiration in the left eye. All surgeries were performed by the same surgeon, and capsulorhexis were made approximately the same size. As we were able to see an important difference in fibrosis development between the aspirated and the non-aspirated eyes of the first patients, we decided to perform the aspiration in both eyes of the next 6 patients. In all of these cases, we can see there is little or none fibrosis of the anterior capsule. The lenses implanted in all cases were either aspheric or toric Acrisov, and none of the eyes had CTR implanted. In our experience, vacuuming lens epithelial cells from the anterior capsule of patients with pseudoexfoliation syndrome greatly reduced the anterior capsule fibrosis, therefore preventing capsular contraction syndrome quite efficiently. Thank you for watching this video. I hope you have enjoyed it.